Hello, Assalamu alaikum. This is me, Dr. Jahangir, and today I'm going to discuss the SK10 July papers, and this is the third paper, and third part. So till now, I have covered the February papers of SK10 on only medicine, and now I am covering the July papers. So in July papers I have covered the two complete papers, and this is the third paper, and this is the third part of the this is the third and the last part of the third paper. So starting with the MCQs, well, over here I want to clear one thing, that in the February papers there are less mistakes. The total mistakes that I faced when I was solving the MCQs were almost 3 to 4. So you can trust the February papers regarding the keys over there. So there are problems only in the July paper. So I am covering the July portion. So coming toward the MCQ number 71 till 70 we have discussed. So women taking some dietary supplements for health and longer life. Now what is the supplement that is used for health and a longer life? That is antioxidant. She developed nausea. Now focus on this. She developed nausea, dry mucous membrane, hyperostosis. What is the cause? This is vitamin A toxicity, not deficiency. This is vitamin A toxicity, not deficiency. Deficiency would cause the that dry eyes, the xerosis, Bittard spots, and night blindness. Well, there is another MCQ that is coming into my mind, that is most common sign of vitamin A deficiency is, तो उसमें आंसर है नाइट ब्लाइंडनेस. और अगर पूछे मोस्ट कॉमन clinical sign of vitamin A deficiency is, so then that is you look for the word dry mucous membrane or Bittard spot. So look for the word xerosis, because this is written in the ophthalmology most of the books, that the most common sign is over here. They are not referring toward the clinical sign, because most of the MCQs they are copy paste from the books, from these books, and in that book, and also in another book of ophthalmology, you can search that. It is clearly written over there that the most common sign of vitamin A deficiency is night blindness, but the most common clinical sign is something else. So probability is that if the word is a clinical sign, then you look for xerosis or first xerosis, if not then Bittard spot. But if that is not in the option, most common sign is night blindness, because this is totally copy paste, and even if you Google it, you will see this is the sign. So they are talking in the context of English. They are not talking in the context of the sign and symptom of the biological term. The rest of the choice is yours. So diagnostic test for infectious mononucleosis is, that is monospot test. The name of the test is monospot test, and it detects the heterophile antibody. So the second name is heterophile antibody test. So you look for the word monospot. If that is not, then look for the word heterophile. And it is caused, infectious mononucleosis is caused by Epstein-Barr virus. Epstein-Barr virus. So look for the word B. So it infects B lymphocytes. It infects B lymphocytes. And what are the atypical lymphocyte? That is, so these are the MCQ that I am referring to. That is called a retrograde study. I am focusing on this again and again because we are doing prospective study, not retrograde study. In the prospective study, you study the theory and then you come toward the MCQs. But the whole and the main thing for the Fcps purpose preparation is you go retrogradely. Now over here you look for the word infectious mononucleosis. Now open your book, look for the word infectious mononucleosis. What is the pathology? What is the best initial test? What is the confirmatory test? what is the causative agent? That is Epstein-Barr. This study will help you a lot in the exam. But if you are studying the infectious mononucleosis, you will forget all the things because you are not actively participating in engaging your brain. There are associations, you have to make associations. So Epstein-Barr virus, it infects the B lymphocytes. And what are the atypical lymphocytes? The atypical lymphocytes are the CD8 cells. CD8 cells. Cytotoxic T cells. CD8 cell. These are activated by B lymphocytes. So in fact, the B lymphocyte then activate this T lymphocytes. Then activate the T lymphocyte. And what is the specificity of heterophile or monospot test? The answer is 100%. This is asked. The specificity is 100%. Runner wins the race. Again, repeating again and again. So if you are having sympathetic stimulation due to exercise, the insulin will go down and glucagon will go up. Now if you utilize this, you will forget this. But if you make a little memory with this, a little concept, you will not forget this. Let's suppose this is your skeletal muscle. When you are exercising, there are stretch sensitive receptors. So when the muscle is stretched, what happens? These channels open. When these channels open, the glucose enters into the skeletal muscle without the use of insulin. So, and that is the reason the doctor asked the diabetic to do exercise, brisk walk. The brisk walk helps this patient to enter the glucose without the use of insulin. So what happens? And the second benefit of exercise is decrease the obesity. When the obesity is decreased, the resistance is decreased, and when the resistance is decreased, so the insulin can work best, and so it decreases the incidence of type 2 diabetes. There is another discussion. So when you are having the stretch sensitive channels, so when the muscle is stretched, these open up. When they open up, the glucose enters into the cell. When the glucose enters into the cell, your blood glucose, it falls. When the blood glucose falls, what happens? Insulin level goes down. Insulin level goes down because there is no need for insulin. But what happens? If your glucose level goes down, the glucagon goes up. And again, the glucagon then inhibits the insulin. Simple. Glucagon inhibits the insulin. So you have decreased insulin and increased glucagon. Decrease insulin and increase glucagon. So coming next, renal pyramids are present in the medulla. So you are having cortex and medulla. These are the simple MCQs. The most differentiating MCQs are those of the physiology mainly, not the anatomy, and they will actually check your concept in those MCQs, and I'm giving you the concept of those MCQs. Selective proteinuria occur in a minimal change disease. There is albuminuria. Only albumin comes out. Now there is another MCQ that normally the albumin does not comes into the urine. Why? Because the albumin has a negative charge. The albumin has negative charge, and the basement membrane in the glomerulus, and the basement membrane inside the nephrons, inside the glomerulus, of course you are having the glomerulus and Bowman capsule. So the basement membrane over there, it has also negative charge. So negative repels negative. Negative repels negative. So the albumin is repelled. The albumin is repelled. So normally there is no proteinuria. And how much protein is expected in a normal person? That is less than 30. Less than 30 milligram per 24 hour. This is normal. 30 to 300, this is microalbuminuria. Now note my each and every word, and you can counter check. I am giving you the reliable references. So less than 30 milligram per 24 hour is what is normal. 30 to 300, this is microalbuminuria, and that occur in diabetic patient. More than 300 is albuminuria or proteinuria. So you keep this in mind as far as the Fcps is concerned. I'm not talking about the clinical things, because in the clinicals we are having other things also. So you are having less than 30 is normal, 30 to 300 is microalbuminuria, and more than 300, this is milligram per 24 hour. Remember this thing in mind, per 24 hour. More than 300, that is, more than 300 is albuminuria or proteinuria, frank proteinuria. 30 to 300 is micro, less than 30 is normal. Focus on this. And your urine dipstick detects how much protein. The answer is 500 or more than 500 per 24 hour. So do you think normal urinary can pick microalbuminuria or the frank proteinuria or albuminuria that is more than 300 but less than 500? The answer is no. So that is why the best physician will advise urine for microalbumin in a patient of diabetes mellitus in order to look for the microalbuminuria, because in urine RE protein will be nil, because the dipstick only detect protein of 500 or more than 500. Less than 500, no protein detection. But if you advise the patient urine for microalbumin, so that will detect this microalbuminuria, and you can start the patient on AC inhibitors, and you can monitor the patient and again, and you will diagnose the patient excellently, because we are not following these guidelines in our routine practice. We look into urinary, there is no protein, and the patient is not hypertensive, but the patient is diabetic. Remember this rule. Even in diabetic patient, if the blood pressure is normal but there is microalbuminuria, start the patient on AC inhibitor, that is tablet EZD 25 mg. It has significant renoprotective function. Coming next. So if dipstick or urinary show +1, that is 500, +2, that is almost 1000, +3, that is almost 1500. So if there is proteinuria and there is WBC as well, or there is leukocyte esterase positive, what is the most sensitive and specific in urinary for the infection for UTI? The answer is leukocyte esterase. So if you are having proteinuria but WBC is also there, so most probably this is infection. Treat the infection first, and then look for the albuminuria. If infection is resolved and there is albuminuria or proteinuria, then there may be glomerular damage. But if there is RBC also, now look for the cast. If there is no cast, then it means the proteinuria is most probably coming from the infection. But if there is cast, it means it's coming from the glomerulus, and there is damage going on in the glomerulus. There is separate video on how to interpret urine RE on my channel. You can watch the full video on that for a clinical practice. So coming next, longest receptive field sensation is carried by, do you know dorsal column sensation and lateral column sensation? If your receptor can detect the 2-point discrimination at a very close distance, then it means there is short receptive field. If I close my eyes and I can detect these two points, so the smallest distance at which I can detect these 2 points is separate 2 points. This is called receptive field. If this receptive field is short, then it means dorsal column sensation. But if I cannot differentiate between these 2 points on a very large surface, then this is large receptive field. There is you may be a little confused, but the dorsal column sensation, whether vibration, proprioception, 2-point discrimination, these are all small receptive field sensation. The pain, the temperature, and the crude touch. What is the difference between the fine touch and crude touch? Fine touch mean this touch. smallest surface area comes in contact. What is crude touch? Larger surface area comes in contact. So there is a large receptive field and there is a small receptive field. So I think you are getting my concept, but if you are not getting my concept, dorsal column smallest receptive field sensation, lateral column largest receptive field sensation, largest receptive field sensation. तो रिसेप्टिव फील्ड सेंसेशन अगर पूछे कि डॉर्सल कॉलम के लिए क्या है, स्मॉल है, क्या मतलब है स्मॉल है? मतलब ये है कि आप स्मॉलर डिस्टेंस पे भी दो पॉइंट्स को एक दूसरे से डिस्क्रिमिनेट कर सकते हो कि ये 2 पॉइंट्स है, कि ये 2 पॉइंट्स है, कि ये 2 पॉइंट्स है। तो स्मॉलेस्ट रिसेप्टिव फील्ड का क्या मतलब है कि आप दो पॉइंट्स को डिफ्रेंशिएट कर सकते हो एक दूसरे से कि ये दो अलग अलग पॉइंट्स हैं। लार्जेस्ट रिसेप्टिव फील्ड का ये है कि आप जो है दो पॉइंट्स को एक दूसरे से डिस्क्रिमिनेट नहीं कर सकते, तो आपका तो लेटरल कॉलम है, क्रूड टच है। इसके अलावा लेफ्स का कौन सा लार्जेस्ट रिसेप्टिव फील्ड है या स्मॉलेस्ट? आंसर इज स्मॉलेस्ट है लेफ्स का, क्योंकि दो पॉइंट को आप डिफ्रेंशिएट कर सकते हो बहुत कम डिस्टेंस पे। लेफ्स का शॉर्टेस्ट है। इसका अलावा जो है वो दूसरा कौन सा है? थंब का भी आप दो पॉइंट पर वो कर सकते हो, तो स्मॉलेस्ट रिसेप्टिव फील्ड, स्मॉलेस्ट रिसेप्टिव फील्ड। और इधर शोल्डर का या स्केपुला का, तो इस पे दो पॉइंट्स अगर आप इतना डिफरेंशिएट नहीं कर सकते जितना लिप्स पे, तो इसे इट हैज़ गॉट लार्जेस्ट रिसेप्टिव फील्ड। रेटिना में पूछा जाता है तो सेंटर ऑफ रेटिना पे स्मॉलेस्ट रिसेप्टिव फील्ड सेंसेशन है, क्योंकि आप दो रेस को इजीली डिफरेंशिएट कर सकते हो। पेरिफेरी ऑफ रेटिना पे लार्जेस्ट रिसेप्टिव फील्ड सेंसेशन है। तो बस इन चीज़ों को रट्टा करो अगर कॉन्सेप्ट आपके दिमाग में नहीं आता। 6-year-old हैविंग हिस्ट्री ऑफ प्रोलॉन्ग ब्लीडिंग ड्यूरिंग सर्कमसिशन, ही इज टेंडर जॉइंट्स। तो टेंडर जॉइंट्स का क्या मतलब है कि उसको ब्लीडिंग हो गई है जॉइंट में। तो कंफर्म द डायग्नोसिस। बेस्ट इनिशियल अगर पूछे तो क्या है? एपीटीटी। कंफर्मेटरी टेस्ट अगर पूछे तो क्या है? फैक्टर 8 एसे। फैक्टर 8 एसे हेमोफीलिया है, हेमोफीलिया है। मेरा एक there is another separate video on my channel regarding the coagulation disorder, and inshallah I have discussed all the MCQs over there. You can watch the complete video. Tumor marker for colorectal carcinoma is there is carcino-embryonic antigen, और इसकी ब्यूटी क्या है? इसकी ब्यूटी ये है, it helps in the response, it is used as a monitoring for relapse. बस ये बात याद रखें। The patient is operated for CA colon. After 5 years, how will you monitor CEA? एक another MCQ है, which of the following is seen both in CA colon and pancreatic CA? Answer is again CEA. Branch of subclavian artery supplying to the shoulder joint, ये dorsal scapular artery है, इसका मैंने रेफरेंस भी शेयर किया है लास्ट वीडियोज़ में, और ये कॉपी पेस्ट है, एक बुक से उन्होंने ये ली है। RH पे मैंने एक सेपरेट वीडियो बनाई है, पूरा आप उसमें देख सकते हैं। इसमें ऑलरेडी हेमोलिटिक डिजीज़ है, इसका मतलब ये है प्रीवियसली मदर जो है वो सेंसिटाइज्ड है ना। व्हाट इज़ मीन बाय सेंसिटाइजेशन? तो ये मैंने पूरा एक्सप्लेन किया है RH इनकम्पेटिबिलिटी पे, और इंशाल्लाह आपका कॉन्सेप्ट इतना क्लियर हो जाएगा कि आपको फिर इस चीज़ में फंसने की ज़रूरत नहीं होती। तो अगर हेमोलिटिक डिजीज़ है तो इसका मतलब ये है मदर सेंसिटाइज्ड है, मदर में एंटीबॉडीज मौजूद हैं, और अगर आपने पॉजिटिव ब्लड फिर दे दिया तो हेमोलिटिक रिएक्शन होगा। एंटीडी आप तब दोगे जब मदर एक्सपोज हो लेकिन वो सेंसिटाइज नहीं है, तो यहाँ पे तो ऑलरेडी सेंसिटाइजेशन हुई है। नो रिएक्शन, नो रिएक्शन विल अकर। यहाँ पे ऐसे ऑप्शन क्या है? हेमोलिटिक रिएक्शन विल अकर। सो कमिंग नेक्स्ट, ड्यूरिंग एम्ब्रियोनिक लाइफ maxillary artery is derived, which of the following are first are? So I will focus less on those MCQs which are clear or which are anatomical. I will focus more on those MCQs which are predominantly conceptual. Foot drop is due to common peroneal narrow, deep peroneal narrow, and sciatic narrow. All of these. But if the question says a person is having trauma to the neck of the fibula, क्योंकि आपका जो फेबुला है, ये सपोज आपका फेबुला है, तो यहाँ पे जो नेक है यहाँ पे कॉमन पेरोनियल नर्व आपकी जाती है, तो फिर आपने कॉमन पेरोनियल पिक करना है। लेकिन यहाँ पे फुट ड्रॉप इज ड्यू टू ऑल ऑफ द अबव। अगर शियाटिका नर्व है तो उसमें भी फुट ड्रॉप होती है, अगर डीप पेरिनियम है उसमें भी, कॉमन पेरिनियम है उसमें भी होती है। एरिथ्रोपोइटिन सिक्रीशन इज इनहिबिटेड बाय, तो एरिथ्रोपोइटिन कब इनहिबिट होगी, सिक्रीशन कब होगी, जब डिक्रीज ऑक्सीजनेशन होगी, पॉइंट नंबर 1। इनहिबिट कब होगी, जब इंक्रीज ऑक्सीजनेशन होगी। तो थियोफाइलिन क्या करता है, कार्डियक आउटपुट को इंक्रीज करता है। जब कार्डियक आउटपुट को इंक्रीज करेगा तो रेनल परफ्यूजन बढ़ाएगा, जब रेनल परफ्यूजन बढ़ाएगा तो किडनीज को मोर ऑक्सीजन जाएगा, जब किडनीज को मोर ऑक्सीजन जाएगा तो एरिथ्रोपोइटिन कम होगा। Which structure lies in the upper third of medulla? Well, there is a separate video on the medulla. Medulla is divided into 3 portions: upper third, middle third, lower third. I have uploaded a separate video with diagrams, and I have focused more on the upper third क्योंकि upper third पे questions आती है। तो upper third पे जो है आपका vestibulocochlear nucleus है, और vestibulocochlear nucleus है, और दूसरा क्या है, हाइपोग्लोसल नर्व है अपर थर्ड में, और एक और न्यूक्लियस है दैट इज विच लाइज इंटीरियरली, वो आगे आ जाएगा। तो यहाँ पे ये सपोज आपका मिड ब्रेन है, ये पोन्स है, ये मेडुला है, और ये सेरेपेलम है। तो ये मेडुला को अपर थर्ड, मिडल थर्ड और लोअर थर्ड, तो अपर थर्ड को जब आप ले लो और उसकी डायसेक्शन करो इस तरह, तो यहाँ पे पोस्टीरियर यहाँ पे आपको क्या मिलेंगे, वेस्टिबुलोकॉक्लियर न्यूक्लियस, और यहाँ पे ये कौन सी बॉडी बनाते हैं, ट्रेपेजॉइड बॉडी। तो वेस्टिबुलोकॉक्लियर न्यूक्लियस लाइज इन द अपर थर्ड ऑफ द मेडुला, और इंटीरियर यहाँ पे 2 और न्यूक्लियाई होते हैं, वो आगे आ रहे हैं। तो वेस्टिबुलोकॉक्लियर न्यूक्लियस, पेशेंट हैज टेनाइटस, फेशियल मसल पैरालिसिस, वेयर इज द लीजन। अगर क्वेश्चन में ये हो कि अ पेशेंट इज हैविंग हाइपर एक्यूसिस का क्या मतलब है, हाइपर एक्यूसिस का मतलब ये है कि हेयरिंग लाउडर देन द नॉर्मल, तो हाइपर एक्यूसिस विद फेशियल न्यूरोपैथी, तो उसमें आंसर क्या होगा, फेशियल कैनाल होगा, और फेशियल कैनाल में वो जगह जहाँ पे आपकी कौन सी नर्व निकलती है, नरोटोस्टेपीडियस। नॉर्मली क्या होता है, आपका जब हाई इंटेंसिटी साउंड जो आपके ईयर को जाती है, हाई इंटेंसिटी साउंड जब ईयर को जाती है, तो आपके जो मिडल एयर बोन्स हैं, खास कर ये स्टेपीडियस, ये जो स्टेपीडियस सपोज मसल है, इसको पीछे से स्टेपीडियल मसल है और उसको स्टेपीडियल नर्व है, ये सपोज स्टेपीडियल मसल है, तो ये बोन को स्टिफ करता है, मिडल एयर या स्टेपीडियस को स्टिप करता है। जब स्टेपीडियस स्टिप हो जाएगा तो ये कंडक्शन ऑफ साउंड नहीं होगी। ये कब, ये नॉर्मल फिनोमेना है, जब आपका साउंड इंटेंसिटी बढ़ जाए तो नॉर्मली क्या होता है, ये स्टेपीडियस जो बोन है स्टेपीडियस, इसके साथ पोस्टीरियर स्टेपीडियस मसल होता है, ये इसको खींच लेता है। जब इसको खींच लेता है नॉर्मली ये तो वाइब्रेट करता है ना साउंड ट्रांसमिशन के वक्त, लेकिन जब हाई साउंड होती है ये प्रोटेक्टिव मैकेनिज्म है ताकि आपके अंदर जो है हाई इंटेंसिटी साउंड ना चला जाए, एज अ प्रोटेक्टिव रिस्पांस है। तो पोस्टीरियरली ये जब स्टेपीडियस मसल एक्टिवेट हो जाता है तो ये स्टिफ हो जाता है और फिर वाइब्रेशन अंदर नहीं जाती और आपका अंदर जो है वो इनर एयर प्रोटेक्ट हो जाता है। आप इस तरह कर ले, कान में हैंड्स फ्री लगा दें और फुल म्यूजिक स्टार्ट कर दें। इनिशियली आपको ज़्यादा फील होगी साउंड, आहिस्ता आहिस्ता फिर आपको कम फील होगी। ये क्यों, आपका स्टेपीडियस मसल एक्टिवेट ताकि अंदर एयर प्रोटेक्ट रहे। इसको कौन सी नर्व सप्लाई, नरोटोस्टेपीडियस, ये नरोटोस्टेपीडियस मसल है और स्टेपीडियस में उसको स्टिफ करता है। जब ये डैमेज होगी तो यू विल हैविंग हाइपर एक्यूसिस। तो यहाँ पे टेनाइटस है, टेनाइटस इज समथिंग एल्स। टेनाइटस मीन रिंगिंग सेंसेशन इन द एब्सेंस, ringing sensation. Tinnitus means ringing sensation in the ear due to some pathology. एक auditory hallucination है, the perception of stimulus in the absence of stimulus, वो auditory hallucination है। Tinnitus is the perception of stimulus but in the presence of pathology. ऑडिटरी हेलुसिनेशन में आपकी पैथोलॉजी नहीं होगी, बिल्कुल एयरटिक होगी, वो ब्रेन में आपका मसला है, यहाँ पे आपकी कोई पैथोलॉजी नहीं है। टेनाइटिस में आपकी यहाँ पैथोलॉजी है, तो सेरेब्रल पोंटाइन एंगल यहाँ पे ज़्यादा ठीक लग रहा है, क्योंकि इसमें आपकी 8 नर्व भी आती है और 7 नर्व दोनों आती है, 8 और 7 दोनों आती है। ये मैं पहले भी बता चुका हूँ कि ये CPSP ने जो यूसीमिडी और MRCP के स्टेम है ना, उसको हाफ किया है, तो उन्होंने क्लूज हटाए हैं। अब पता नहीं और क्लूज इसमें थे या नहीं थे, या पूरा रिकॉल है, मुझे कुछ पता नहीं है, लेकिन हाइपर एक्यूस और टेनाइटिस के बेस पे आप डिफरेंशिएट कर सकते हो। मिडल एज विथ कोरिफॉर्म मूवमेंट्स, एपैथी एंड डिप्रेशन, ऑटोसोमल डोमिनेंट, तो ये तो हंटिंगटन कोरिया है, इसको रटलाइज करो बार बार आता है। एपिकार्डियम सप्लाइड बाई, यहाँ पे मैंने एक सेपरेट वीडियो दी है प्रीवियसली, ये इस वीडियो के साथ दूसरे वीडियोस भी पीछे देख ले आप, सिर्फ ये वीडियो ना देखें, क्योंकि उसमें मैंने पूरा एक्सप्लेन किया है कि हार्ट के 3 चैम्बर्स हैं, एंडोकार्डियम, मायोकार्डियम, पेरिकार्डियम। फिर पेरिकार्डियम के 2 पोर्शन है, फाइब्रस पेरिकार्डियम है और सिरस पेरिकार्डियम है। फिर सिरस पेरिकार्डियम के अगेन 2 पोर्शन है, एक विसरल लेयर है और एक पेराइटल लेयर है। तो विसरल लेयर ऑफ द सिरस पेरिकार्डियम इज कॉल्ड एपिकार्डियम। This is endocardium, myocardium, pericardium. Pericardium, if you see on the microscope, it is divided into 2 main parts. One is the fibrous pericardium, this is the serous pericardium. And when you see again this, you will again see 2 parts. This is the parietal layer of the serous pericardium, and this is the visceral layer of the serous pericardium. This visceral layer of the serous pericardium is called epicardium. And the blood supply of this is coronary arteries. And the blood supply of the fibrous pericardium and the parietal layer of the serous pericardium is pericardiophrenik artery. Similarly, the nerve supply is again different. For the epicardium or the visceral layer of the serous pericardium, the answer is cardiac plexus. And for the parietal layer of the serous pericardium and the fibrous pericardium, the answer is phrenic nerve. And in the cardiac plexus, you are having sympathetic and parasympathetic both. So sympathetic is derived from the sympathetic chain, and the parasympathetic is derived from, answer is vagus nerve. Coming next. A weightlifter was lifting weight in a competition. Suddenly his arm gave up and he dropped the weight. What is responsible for that? The answer is Golgi tendon organs. Explained in the detail, and I have uploaded a reference with comparison between the Golgi tendon organ and the muscle spindle. You can differentiate among the two, because a weightlifter was lifting the weight. So if you are lifting the weight, so your muscle contracts. So when your muscle contracts, this is something else. And when someone puts the weight on your both limbs, 1, 2, 3, 4, so that is something else. So I think I should share the reference again. So this is that reference I was talking about, Golgi tendon organ and muscle spindle. So correct this. Muscle spindle, muscle length and change of muscle length, that is associated with only length, and this is associated with muscle tension and muscle force. So if a heavy weight lifting is I'm changing it according to the reference. If a heavy weight lifting is lifting something, he is producing muscle tension and muscle force. But if you are tapping the tendon hammer, you are changing the length without affecting the tension. So over here you can see a sudden, the last paragraph, a sudden relaxation, can you focus on it? Sudden relaxation when a weightlifter uses extremely heavy weights. So if you are creating muscle tension in the muscle, so what happens? That reflex is activated. So there's another MCQ, the myotatic stretch reflex and the inverse myotatic stretch reflex. The Golgi tendon organ is associated with the inverse myotatic stretch reflex, and the muscle spindle is associated with the myotatic stretch reflex. So it causes the stretch muscle to contract, and it causes muscle relaxation of the agonist muscle. So you can see sudden relaxation when a weight lifter uses extremely heavy weight. So you can see the other things in this chart also, so focus on them also. So the muscle spindle and Golgi tendon organ. The Golgi tendon organ is for the heavy weight lifter. The muscle spindle is for the deep tendon reflexes when you are checking. So when you are checking the deep tendon reflexes, you are not actually changing the tension in the muscle, you are actually changing the length of the muscle. But when you are creating a force, creating a tension in the muscle, then there will be activation of Golgi tendon organ. Why it is called tendon? Because it lies in the tendon of muscle and it prevents the tendon. The muscle spindle prevents the muscle. So coming back toward the topic. So over here, Golgi tendon organ. During embryonic maxillary supplies, which are first, this was the MCQ that I talking about. Upper one third of medulla contains, that is, inferior olivary nucleus. But what if there is both inferior olivary nucleus and vestibulocochlear nucleus in the same stem? The answer will be inferior olivary nucleus, because the upper third is called olivary portion of the medulla. The discriminating feature is the olivary. So the inferior olivary nucleus, upper third of medulla contains inferior olivary nucleus. But if, let's suppose this is your upper third of medulla, interior you are having inferior olivary nucleus, posterior you are having vestibulocochlear nucleus. So if the question says interior portion of the upper third of the medulla, inferior olivary nucleus, posterior portion of the upper third of medulla, the answer will be vestibulocochlear nucleus. Which of the following is spore forming bacteria? Clostridium. What about the others? So this is the reference, Clostridium, spore forming. Coming back to a topic, you see this is a very difficult thing. You are checking and counter checking the MCQs. First pass metabolism of a drug can be avoided by IV more than sublingual. Pain and temperature carried by the lateral spinothalamic tract. The dorsal carries the vibration. 2-point discrimination and proprioception. AC inhibitor given in pregnancy will cause the renal agenesis because it causes decrease in GFR. It causes the efferent vasoconstriction and the efferent vasodilation. Testosterone, lowest in preschool. So your testosterone level, that is lowest in preschool. Enzyme which combines two and make a single compound is synthetase, that is mainly synthetase. Airborne infection is TB. TB is airborne. Pulmonary anthrax is airborne. So TB and anthrax both. But if the question is having pulmonary anthrax, then that is the right answer, but not every anthrax. Cutaneous anthrax cannot through pulmonary route. So over here I will pick the TB. Major contributor of urea in the body is ammonia, but the main transporter of the ammonia is glutamine. It is actually glutamate which combined with the amino group and becomes glutamine. That is called glutamine second, but that is actually glutamate. So the main transporter of the urea is glutamate in the form of glutamine. Antidote for warfarin is vitamin K. Regarding growth hormone, both are right. It is a polypeptide and it initiates growth of bone and cartilage by somatomedin. Maximum percentage of carbon dioxide in the blood is found is, so as a bicarbonate, that is 70%. That is the main thing. What is the difference between carbaminohemoglobin and carboxyhemoglobin? Carbaminohemoglobin is carbon dioxide is combined with hemoglobin. Carboxyhemoglobin means carbon monoxide is combined with hemoglobin. That is carbon monoxide poisoning. That is something else. Carbaminohemoglobin is normal. Carboxyhemoglobin is carbon monoxide poisoning. So the CO2 is carried as a 70% is a case of bicarbonate, 23% combined with the hemoglobin, and 7% in the blood, and 7% in the blood as such. The cause of primary hepatic carcinoma is, they are not talking about the most common cause of primary hepatic carcinoma. They are talking about the cause of primary hepatic carcinoma, and the answer is both. So over here, right option is C. Bifurcation of common carotid artery, that is the upper border of thyroid cartilage goes laterally, there is bifurcation. Worsen prognosis in sepsis is DIC. Severe form of sepsis is called DIC. Bilateral damage to hippocampus is the acute memory is converted into long-term memory, chronic. Short-term memory is converted into long-term through hippocampus. So answer over here is C. Ability to encode events of recent past into long-term memory. Most common large vessel anomaly is, the answer is PDA. They are talking about the vessel anomaly. Most common congenital heart anomaly is VST. Most common congenital heart anomaly that is diagnosed in adult is ASD. Now focus on this. Most common congenital anomaly at birth is tetralogy of Fallot, TOF, because VSD is not diagnosed at birth. Presentation is a bit late. So most common congenital heart anomaly in adult is ASD. Most common congenital heart anomaly overall is VSD. Most common congenital anomaly diagnosed within the first 24 hours or at birth is tetralogy of Fallot. Wave during arithmetic mean solving is, I don't know what they are asking. Beta. Transitional epithelium of the bladder and transitional epithelium of the ureter. Of the bladder, it is derived from the endoderm, and of the ureter, that is derived from the mesoderm, from the mesenchyme. Reference shared on my Facebook group, that is FCPS by Dr. Jahangir. FCPS in clinical points. Hypospadias defect in urogenital folds, that is discussed in my gynae pinks. Well, the basic rule of my video is not, these are not only for SK10. All specialties can watch it. A farmer with lung lesion, so the answer is hypersensitivity pneumonitis. The answer for this is hypersensitivity pneumonitis or farmer lung disease. Well, there is a difference between aspergillosis and aspergilloma. Aspergilloma is a fungal mass. Aspergillosis is a condition which is caused in a long-standing uncontrolled asthmatics. So focus on that. Increased heart rate will affect diastole more than systole. Right to left shift is caused by right to left. So the left shift is caused by carbon monoxide poisoning. Increase in all of the following causes shift to the right except in pH. The decrease in pH causes shift toward the right. Increase in temperature, increase in CO2, they will cause shift toward the right. They will cause shift. So that is all for today.